I'm Dr. David Maloney from the Fred Hutchinson Seattle, my colleague Johannes from Dresden. And we're here talking about cellular immunotherapy at the iwCLL meeting in Edinburgh. And great meeting so far. We're learning a lot about basic science on day one, which was, I thought, quite overwhelming and extensive. And now we're getting today was into clinical, and tomorrow we get into some of the cellular immunotherapy. What are your impressions so far?
So for me, it's always a very exciting meeting, giving me the opportunity to really dive deep into the CLL issue, understanding biology a little bit better, learning about the whole spectrum of treatment which will become available or is available. As you said, today we started with first-line treatment. The next session in the afternoon will be treatment for relapsed refractory CLL, and this is where, for some patients, already the indication for cell therapy starts.
Yeah, it's I was struck by today that we're seeing a shift, a complete shift, paradigm shift in obviously the treatment of CLL, whereas before the relapsed refractory patients were relapsed and refractory because they were coming off of chemoimmunotherapy. FCR was the standard regimen. So all the patients we're now seeing in the relapsed refractory setting have already failed chemoimmunotherapy, but then now they're failing the novel agents, and that's why they're coming to fourth and fifth and sixth line treatments, which was where our experience is with CAR T cells. But that's not going to last forever, because as we saw today, it seems like novel therapies are going to be the wave of the future. And so the question is, how long are those novel therapies going to keep working, and will people still have that chronically relapsing pattern after now a BTK and BCR-directed therapy?
So what we notice already is that the definition of high-risk CLL, defined from a clinical point of view, relapsed refractory CLL has to be defined in a new way. So we start dealing with the first patients who have genetically defined high-risk disease, defined by a mutant or deleted TP53, and those patients should not get chemotherapy. So these patients will never achieve a state of refractoriness towards chemoimmunotherapy. And actually we started offering allogeneic transplantation, which is right now in Germany the only opportunity which we have with respect to cellular therapy for those patients.
Yeah, we did much the same thing, although it was adopted much later in the disease course. And so I think in the United States there's a much more hesitancy to use allogeneic stem cell transplant, even though our data and the data from your group showed that you can get long-term remissions and probably cures using bone marrow transplant, but at the risk of now graft-versus-host disease and chronic infections, which does cause a substantial non-relapse mortality. So the new thing that obviously everyone's talking about are the cellular immunotherapies with the genetically altered cells. And so the CAR T cells were now getting some experience. We treated about 43 patients on 2 sequential cohorts with a 4-1BB containing CD19-directed CAR, and with or without concurrent ibrutinib. And that was done on the rationale that ibrutinib can actually make better functioning CAR T cells, and that it also might decrease the symptoms that we see, the cytokine release syndrome and maybe even the neurologic toxicity. So the data so far support that this can be a tremendously active treatment, even in fifth and sixth line patients who are refractory to chemoimmunotherapy and now refractory in most cases to ibrutinib, and over 50% of the cases refractory to venetoclax. So this provides an opportunity. I think we're getting high rates of molecular remission, and we're doing it from a disease state that you probably wouldn't transplant. I mean, I don't know what the criteria are in Germany, but do you transplant patients with bulky disease for allotransplants?
So actually, as a desperate approach, you can do it, but results are definitely better if you offer allogeneic transplantation as a kind of consolidating treatment. So when we right now think of the place of allogeneic stem cell transplantation, we always think about which opportunity remains, which will help us to bring a patient in remission so that we can then proceed to transplantation. And indeed, this might be completely different once CARs will be available also in Germany. These drugs are useful and are efficacious to bring patients into remission. The big question is, how long will these remissions last, and what are your insights in this?
Yeah. Well, we've found that we're getting a pretty deep remission. You know, over 80% of patients will go to MRD negative remissions at the conventionally defined rate. But
by the way, this is what we also observed with allogeneic transplantation. This
Yeah.
rate of MRD negativity, but then we see relapse.
Yeah, and I think what we've started doing is next generation sequencing, looking for the clone. And if you go to that level, then about 50 to 60% of those other otherwise MRD negative remissions appear to be deep sequence negative as well. And that seems to, at least with early results, predict a longer remission. Now, are those patients cured? That's really the big question. And I don't think we know at this point if that's the case, but we're all hopeful. My lead patient is now out over 4.5 years and had failed an allogeneic transplant as his consolidation originally, so now is in a remission after CAR T. So, I think it might provide that additional deeper remission that could cure people. Now that said, in ALL, our position is a little bit different. We view CAR T cells as a road to transplant as opposed to a barrier. And so I think we're still doing. At least at our center, we're recommending allo transplants for people who can get a transplant, because transplanting patients with a lot of ALL just doesn't work. And so I think that there's room for both processes. So then we also are going to talk about using other cells, and Katie Rizvani from MD Anderson is going to talk about the use of an NK CAR, and she has some very exciting results where they genetically engineered a CAR to express, or an NK cell to express a CAR and provide then help for the cells to actually grow. And using these cells, they're seeing pretty good activity in CLL and some lymphoma patients, and we're excited to hear her update about that. So those approaches are not yet available, at least in CLL in Germany, but the commercial lymphoma CARs are available.
We're getting off the ground with giving commercial products, but it is so actually it's a big struggle. The main issue is reimbursement, and in Germany we have another step which is kind of obstacle, which is that first centers have to get certified. We have a selected set of 26 centers who are entitled to offer cell therapy, this modern kind of cell therapy. Centers who do not belong to this group are not allowed to give them, or do not get reimbursement. They only have the possibility to give these cells inside clinical trials. So the whole field is right now highly regulated, and it is a highly bureaucratic issue to get patients to the point that we can collect cells from them and produce CARs. So right now we're at the beginning of this development in Germany, and it will take, I think, a couple of years until we will have access to the first product for patients with CLL, for the first commercial product. Right now there's no, at least I don't know which trial is which development is so far that we can expect approval of a product for this indication. So from our perspective right now, we have to deal for the next couple of years still with the opportunity of offering allogeneic stem cell transplantation. And as you said before, it's a trade-off. We know about long-term activity of allogeneic transplants. We are pretty aware of the toxicity of this procedure. So it's always weighing risks and benefits and treatment alternatives, whether or not we make the decision to offer transplantation. What I'm interested in is, how do you select patients for trials with this indication, CLL? Do they all have to be chemoimmunotherapy refractory, or do you also...
Yeah, that's really a great question, because it's an evolving picture. When I wrote the original trial, I said you had to be chemoimmunotherapy refractory because that was the standard of care. But then obviously the data came out that you shouldn't give those patients chemoimmunotherapy that have, for example, 17p deletion. And so we had to evolve that and change it to or inpatient, if that was not indicated. But I think right now what we're seeing is these patients need to be really refractory to ibrutinib or progressing on ibrutinib, and then probably treated with venetoclax and not having obviously a fabulous response. That's, I believe, the unmet need, and that's the group where it'll initially, if all goes well, would get approved. I know we're doing studies with JCAR17 in that space that Tanya Siddiqui has presented, and that looks very encouraging. There's a reasonable, a very good response rate and reasonable risk in terms of cytokine release syndrome. And I'll be presenting a little bit of that data, but that looks very exciting. But that's not going to be the future, I believe. The future is just like in large cell lymphoma, we're already trying to move things up. So that right now they're approved in the large cell lymphoma setting for third line therapy, but clinical trials are going on now to try to beat auto transplant, which is really our standard of care for responding patients, to first salvage. And so I think that has a chance of success. We'll see. Some of those trials I think are nearly fully enrolled, and the KITE trial, for example, and we should see the readout in one of those 3 trials soon. But I think the same thing will happen in CLL. Once, the risk of the treatment really is correlated with the disease burden. And if you were doing this as, for example, consolidation, potentially you could consolidate remissions after a short course of ibrutinib and venetoclax, and think about it that way. And you might then have a treatment that literally has no toxicity because it's given to such a low disease burden state. Now there's controversies with that because you might need some antigen load or burden to get the T cells, up and running and proliferating. But that's what I think the future is. The future could be, very early on, reduce disease, consolidate with a CAR or 2 CARs, and we have a different approach to treatment of cancer.
But perhaps you also agree that it will be in a setting after pathway inhibitor failure.
Initially, I think initially it has to be because I think that the results are too good with ibrutinib and venetoclax. I mean, the risks are relatively low, and I think the results are very good. So I would, even though I think the risks of CAR T cells are generally manageable, it's not zero, and there have been deaths on trials in these relapsed refractory populations. But that's true, obviously, of transplant and everything else. And so it's a matter of balancing risks. And in that 3rd, 4th, 5th line treatment space, I don't think there's a lot of things that work at all. And this is an example that produces very impressive remissions, at least in the patients treated so far.
So how do you deal right now with a patient who is, for example, failed on ibrutinib and then is on venetoclax, is after 1 year still MRD positive? And you, so if you have the chance to put him on a clinical trial, I think you will do this on a cell therapy trial. If you don't have the chance, will you offer allogeneic stem cell transplantation?
Well, we will offer it. We discuss it every time the transplant option. Most patients, in my experience, don't want to do the allogeneic transplant in the United States. They feel that they have more options with these conventional treatment, with more conventional treatment, staying on with the venetoclax and monitoring. If patients have high-risk disease and they still have disease on venetoclax or been treated with venetoclax, then they would be eligible for some of our clinical trials. If they don't have high-risk disease, then they actually have to be another line down, 3rd and 4th line, before they can be treated. So I think everyone's still trying to learn, and as per usual, you bring your new treatment into the kind of the end stage disease and see what the toxicity profile is and what the activity is. If that's favorable, then you start moving it up. And I think that we're going to see that CAR T cells will become very manageable, especially if you can do it in patients with low risk disease, low disease burden, not low risk disease, low disease burden, where I think the cytokine release syndrome and neurologic toxicity risks will be much lower.